Okay, welcome everyone to our 18th seminar of the Aphasia CRE seminar series. I'm Caroline Baker, co-facilitator of the seminar series. La Trobe University acknowledges that this event and our participants are located on the lands of many traditional custodians in Australia. We pay our respects to Indigenous elders past, present and emerging, and extend this respect to any Indigenous participants joining us online today. We warmly welcome you to this very special seminar, the fourth one in the series to cross international borders. Today we cross to the UK from Australia while gathering many attendees internationally for Dr. Anna Volkmer's presentation, The Three Variants of Primary Progressive Aphasia. What are they and what helps? Before the formal introduction, let's briefly cover some housekeeping. Please be patient with us and the technology today. We have switched software platforms to the Zoom webinar package. Our apologies in advance if there are any disruptions to your viewing during this seminar. This seminar is being recorded and it will be available for access along with past webinar videos via the website. Just click on the resources tab. Videos are usually uploaded 2 weeks after each seminar, and we acknowledge that many are facing difficult and uncertain times during COVID. So a reminder to you that the CRE has developed a repository of aphasia-friendly COVID-19 resources. These have been sourced from across the world, and you are welcome to use these resources in your practice. If you've joined previous seminars, you'll notice that we have switched platforms for facilitating seminar questions. We now use the question and answer function on the Zoom toolbar at the bottom of your screen. Enter your question at any time throughout the presentation. You will also be able to see questions asked by other audience members. You can like or upvote a question to show those of most interest to the group. And Dr. Volkmer will answer as many questions as time will allow at the end of the presentation. Please reserve this Q&A space for questions only and no other comments. And as always, we're on social media. So please engage with us via Twitter and Facebook, and feel free to tweet along today and use the hashtag AphasiaCRE. And if you haven't already done so, please join us as a member of the Aphasia CRE. We welcome people with aphasia, their family, friends, health professionals, researchers and organisations to our Aphasia CRE community of practice. Benefits to members of the community of practice include a regular newsletter, updates about events and activities, contributions to research, networking opportunities and more. The CRE is always looking for financial support. If you wish to donate, please see our website for details. Now, I'm delighted to introduce Dr. Anna Volkmer. Dr. Volkmer completed her clinical training in speech and language therapy at University College London in 2002. Since then, she has worked clinically with adults with acquired communication difficulties, developing a particular interest in primary progressive aphasia whilst working in Melbourne in 2008. She returned to the UK and wrote a book on assessment and therapy for language and cognitive difficulties in dementia and other progressive diseases. And this book is available through the publishers J&R Press. During her PhD, Dr. Volkmer developed and piloted a communication partner training intervention for people with primary progressive aphasia and their families, entitled Better Conversations with PPA. She is now employed as a lecturer and senior researcher at University College London, continuing her research in this area. She also continues to work clinically at the National Hospital for Neurology and Neurosurgery in London and is the co-lead of the PPA support group at UCL. Thanks so much, Anna, for joining us bright and early your time in London.
Thank you for having me.
Great.
So I will share my slides now.
Great, thank you.
Thank you. There we go. Well, thank you so very much for having me. I wish I were back in Melbourne in the flesh. I spent 5 years working in Melbourne from 2005 to 2010. And it was when I was working at Royal Park that I started working with people with primary progressive aphasia, working with alongside Dr. Margaret Posebon. And since then, I've continued that trend and have worked with people with primary progressive aphasia and really realised that the lack of research evidence around interventions, and this is what inspired me to develop and do research in this area. And so I've been asked today to talk about the 3 variants of primary progressive aphasia. So I'm going to start the talk by giving you an overview, and then I'm going to give you a speedy tour through some of the interventions that we have available for primary progressive aphasia as speech and language therapists. So I'm going to start by giving you an overview of dementia. So I often talk about dementia as an umbrella term, actually, and to help us understand where primary progressive aphasia fits, I'm just going to set the scene in terms of the main types of dementia. So there are 4 main types of dementia. There's Alzheimer's disease, which is associated with underlying neurofibrillary tangles and frontotemporal dementia, which is associated with the tau protein, and then Lewy body dementia, which is associated with the Lewy bodies. And then, of course, there's vascular dementia, which is associated with changes in the vascular function. So these are the typical dementias, which are associated with less typical dementias. So Alzheimer's disease, typical Alzheimer's disease is what we associate with a memory-led dementia, so where an individual presents with memory symptoms as the initial and most dominant symptoms. Now, there are a couple of different types of less typical or atypical types of Alzheimer's disease. There's posterior cortical atrophy, which is where the Alzheimer's disease results in atrophy to the posterior cortices of the brain. So more typically, the Alzheimer's starts by affecting the hippocampi and maybe some right hemisphere structures, but a posterior cortical atrophy will affect the posterior hemispheres, resulting in a visual-led dementia. And actually, a logopenic variant of PPA is a result of an Alzheimer's pathology. So a logopenic PPA fits into an atypical Alzheimer's presentations, and that results in atrophy to the left temporal parietal regions. And I'm going to give you an overview of the theory now and then repeat it a little bit as we go along so that you don't have to absorb it all immediately. So what are we talking about when we're talking about frontotemporal dementias? So quite typically, we think of frontotemporal behaviours as being associated with behavioural variant dementias. So these are resulting from a tau protein, which causes atrophy to the frontal regions of the brain. And typically, we've thought of primary progressive aphasia as being all of the 3 variants as being part of the frontotemporal dementia family. What we now understand, it's actually mainly the semantic variants and the non-fluent agrammatic variants of PPA, which sit under the banner of frontotemporal dementia. Okay, and then there's the 2 main types of Lewy body dementia. So there's dementia with Lewy bodies, and then there's Parkinson's disease dementia, and then the other types of vascular dementia. And of course, there are hundreds of other types of dementias, but I'm going to focus on these three primary progressive aphasias, okay, in this talk today. So I'm going to start by describing how we diagnose primary progressive aphasia in the clinical setting. So primary progressive aphasia was really identified in the Western research literature, in the English-speaking research literature, by Marcel Mezlem back in the early 80s. And he started defining he's a neurologist, and he just started defining a diagnostic criteria for this. And in 2011, a whole bunch of neurologists and internationally got together and came up with an international diagnostic criteria that we still use today. And this actually incorporated the original diagnostic criteria that Professor Mezlem put together. So essentially, primary progressive aphasia is a language-led dementia. So where the most prominent clinical feature that is impacting on a person's activities of daily living is language. So aphasia should be the most prominent deficit. We now understand that most people with PPA will also have some underlying cognitive deficits, perhaps right from the beginning, but actually it's as the person progresses that those deficits become a bit more significant. But at the beginning of the disease process, the language impairment should be the most significant, to the exclusion of other non-degenerative difficulties and psychiatric diagnoses and any other kind of dementia types, as well as any other behavioural disturbances. So how common is PPA? So Marcel Mezlem estimated that in 2001 that perhaps up to 20% of people with dementia might have primary progressive aphasia. In terms of what we actually know about the people living with dementia, these estimates are a bit more conservative. So Coyle Gilchrist is a researcher in the UK, and he lives in Cambridgeshire, and he looked at the number of people in Cambridgeshire living with a PPA. Well, he looked at FTD, frontotemporal dementia, and he was able to, he picked out the number of people with PPA related to frontotemporal dementia. So what we're really looking at here are only the semantic variant PPA and people living with non-fluent variant PPA. So he estimated that it was around 11 in 100,000. So perhaps if we're looking conservatively, about 3,000 people in England living with either a semantic variant or a non-fluent variant, which is an incredibly conservative estimate. In reality, what we do know for speech and language therapists is that referrals to speech and language therapy have increased. And that is the case across the UK, across Australia, across Germany, and parts of America. This is the data we are collecting from speech and language therapists that tells us these referrals are increasing. So what are the three types of PPA that I've been talking about? What I'm going to do is I'm going to talk about each type of PPA in terms of the underlying pathology, just to give you a more specific idea of what I mean. I'm going to talk about the area of atrophy in terms of the brain, and then I'm going to talk about the symptoms. And I feel it's really important to divide this up, because in actual fact, when people come to clinic, the diagnosis of somebody with PPA is led by their symptoms. We can do brain scanning, we can look at the area of atrophy, but actually we cannot conclusively identify the pathology until post-mortem, because we cannot just take a slice of the brain and have a look at it. So really what we're looking at is the symptoms that somebody's presenting with and the site of atrophy, and the brain imaging isn't always definitive. So in actual fact, we're really hugely relying on their symptoms. So I'm going to take you through so you can get a real idea of what I'm describing. So we're going to start with semantic variant PPA. Now, all of these PPAs will present with, on imaging, with more atrophy in the left hemisphere. And a semantic variant PPA is perhaps one of the clearer variants. And often this is a type of PPA where people do or are more likely to present with something that can be seen on imaging. And what you can see here is that there'll be atrophy in the left hemisphere, in the anterior, inferior area of the temporal lobe. And it's very clear. It's almost like somebody's taken a knife to this part of the brain. So it's a really straight edge on imaging, as though that someone sliced off that part of the brain. And this type of PPA is typically associated with a very specific protein, so a TDP43 type C pathology, okay? And there's a really good association in the research literature between semantic variant and this type of atrophy, and semantic variant and this type of these proteins. So what do we see when we meet somebody with semantic variant PPA? Well, these are people who are very fluent as they're speaking. Their speech, their articulation is intact. These are people who will produce phonologically correct words and grammatically correct sentences, but they have difficulties with semantic knowledge. So their object naming will be impaired. Their single word comprehension will be impaired. So often their speech, despite being fluent, will be empty. So they'll use phrases, instead of using proper nouns, they might use that, or instead of using someone's name, they'll use him or her. Okay, so they'll often also, rather than using very specific semantic words, they'll use more superordinate semantic category names. So for example, instead of saying, look at that Volkswagen, they might say, look at that car. So I was working with somebody with semantic variant a couple of days ago, and we were talking about his car names being something he used to really enjoy talking about, and not being able to identify those anymore. Or for example, instead of saying perhaps tabby cat, they might say animal, look at that animal. So in addition to that, people with semantic variant PPA present with reading difficulty, so a surface dyslexia. So for example, if you ask them to read a word like island, they will say island. So they're really, this is a real noticeable feature of semantic variant PPA. Now I've put here on the slide that people with semantic variant PPA can stay on topic and expand the topic. That's really perhaps in the initial stages, but actually as people progress, their ability to talk about a range of topics deteriorates. So often people will say to me, oh, my husband's really selfish and he's not interested in what I'm interested in. And actually I find it really helpful to think about it. And there's another speech therapist in the north of England, Dr. Jackie Kindell, who will say you can only talk about what you know about. So if a person with semantic variant PPA's knowledge is shrinking, their ability to talk about a range of topics is shrinking. And I think that's a really helpful analogy for family members when I'm describing what's happening to their loved ones. So this is an example of what can happen on testing. You know, you present somebody with object pictures and they will say, I don't know, it's an animal. I've no idea, is it living? You know, it's not uncommon for people to ask those questions back to you. I was working with somebody with semantic variant PPA just recently, and I said, how many siblings have you got? And he said, what's a sibling? So that kind of asking those questions back to the examiner is often quite a hallmark feature for you to look out for. So non-fluent agrammatic variant PPA. This is when we look at brain imaging. Yes, the atrophy tends to be more in the left hemisphere, but on brain imaging, these features are often quite subtle in the early stages and quite difficult to identify on imaging. But if they are, what we do see is that the atrophy tends to be more in the frontal insular and anterior superior temporal gyrus. So that junction between the frontal and temporal lobes of the brain. And people with non-fluent variant PPA, and I'm going to talk about this in a bit more detail in a moment, they present with an apraxia and or an agrammatism. But what we're seeing more and more is that people who present with a pure apraxia are perhaps more likely to have an underlying tau protein, whilst people with an agrammatism are more likely to have an underlying TDP43 protein. Yet there is some heterogeneity in terms of the underlying pathologies in the non-fluent variant group. And I've seen lots of people who will present with symptoms of non-fluent variant PPA, and over time we realize that they have an underlying PSP pathology or a corticobasal syndrome or an MND pathology as their motor symptoms develop. And in some ways this is a group that I worry about more. So in terms of their motor symptoms developing and the impact on dysphagia as well. So and often I've found clinically that as those motor symptoms develop, the dysphagia can develop quite relatively quickly. So I'm always mindful that this group don't fall through the gaps, so to speak, and that they get the support from us that they need, particularly in terms of dysphagia as well as communication. So what does this look like? So people with non-fluent variant, I mentioned this before, they present with an apraxia, so they are dysfluent. They also may present with an agrammatism. So this impacts both their expression and their receptive language. And people with non-fluent variant are generally, their comprehension, especially at the beginning for sentences, is also pretty good. And then over time, their comprehension of grammar deteriorates. So they're still able to process single words. And so this type of PPA, they're actually really good candidates for AAC because of this. But I would say with all the PPA types, I'm talking mainly about the language, but actually people with non-fluent variant will also develop apathy in particular, and perhaps the lack of initiation. So over time, people often find using AAC technology and even low-tech devices fairly tricky. So, and I should have said with semantic variant that their underlying cognitive deficits will also develop, often associated with the kind of more behavioral variant pathology that's developing. So people might become more disinhibited and inappropriate and lack empathy. So that's what we're looking at. In semantic variant, it's these kind of more behavioral difficulties. With non-fluent variant, it's often a lack of initiation, this apathy that develops cognitively. So what does the language look like in non-fluent variant PPA? Well, here's an example of somebody with a kind of telegraphic output. So this is, of course, a cookie theft picture this person is describing. And so you can see it's this single word use. Before people progress to single word use, they will often, with their agrammatism, start losing the prepositions and the determiners. So they'll be using much simpler sentence structures as their agrammatism develops, and then they become more telegraphic. And ultimately, people with non-fluent variant will, we see that some of them become mute, in fact, as the disease progresses. So logopenic variant PPA, what am I talking about here? So this is the type of PPA that we associate with an underlying Alzheimer's pathology. Okay, so this is where people present with, again, on imaging, more atrophy in the left hemisphere at the temporal parietal junction. And what you can see here on the imaging as well is there's early involvement of these hippocampi. Okay, so the people with logopenic variant PPA, these are the group that perhaps have the most heterogeneous language and presentation, actually. So in general, people with this type start off by reporting a difficulty in word retrieval. So they know what they want to say, but they can't find the word from their lexicon. So in contrast to people with semantic variant who've lost the concepts knowledge, this group will know they'll know the concepts they want to talk about, but they'll be struggling to find the word. Their articulation that will be intact, so they're not distorting their vowels, they're not distorting their consonants, they haven't got a dyspraxia. So although they may develop they may make phonemic errors over time. So phonemic paraphasias, they might, for example, say manimal instead of animal, or papal instead of apple. But what we tend to find initially in particular is they'll start trying to word find or self-correct these errors. So you might find that they appear less fluent because of these word finding gaps in their speech. So because they're trying to self-correct their speech. We think at the beginning actually that people with logopenic variant also have difficulties with phonological awareness as well. So we think there's more going on in terms of their language comprehension than previously realized. And then what we find is that over time, because this is theorized to be associated with a phonological loop disorder or a working memory deficit, so that function that allows us, in the olden days to remember telephone numbers and then quickly forget them, that kind of, we would rehearse it, 88627, and then dial the number and it was gone. This type of PPA means that people can't do that. So if you give them a sentence, so for example, on the comprehensive aphasia test, I think one of the sentences for sentence repetition is something like, the boy and girl went to the top of the hill and admired the view. And when I give that sentence to people, often I get something, the semantics are there, but the actual words aren't. So I get something more like, the children went up the grassy mound and looked around. And so people will know the meanings, and often therapists will say, well, they made a semantic error, and I ask people to really think about, was it a semantic error? So were they were they actually understanding the semantics of the sentence? So did they get the gist? So patients will say to me, I got the gist of what they were saying, I just couldn't get the specifics. So it's really worth looking at in detail at what those responses are when you're concerned that it might be a semantic error. But a digit span is perhaps an easier way of doing it. So often people will find digit span repetition really, really difficult. So they can understand the semantics of single words in particular, their grammar is basically intact, they're fluent, but their working memory is meaning that it's really, really hard to articulate words and retain specific words in terms of comprehension. And again, this is the cookie theft. So people will produce these kind of word finding pauses, not to be confused with a dyspraxia. So people will say kind of, oh, they're on the steps and the cookie things, and then the girl on the furniture and the curtains, and so you get these hesitations and these gaps, these pauses related to this word finding. So here's a very quick interpretation for you to use clinically. So this was developed in one of our papers from the clinic I worked in. So if a person is presenting with a progressive language difficulty and their speech is effortful, so if they have a dyspraxia, it's more likely to be a non-fluent variant. So this summary is quite helpful in terms of a flowchart, in terms of making decisions about the people you're working with. So if they're apraxic, then they're more likely to have non-fluent variant. If they're agrammatic, they're more likely to have non-fluent variant. If their repetition of phrases is affected, so if they're finding that their working memory is impaired, then they're more likely to have a logopenic variant. If their understanding of word meaning is affected, so their semantics are affected, they're more likely to have a semantic variant. That said, there is a whole group of people who present with an atypical variant of PPA, and atypical variants might mean that people present with mixed variants, or they present with something that is similar but doesn't quite fit. Okay, and there are some estimates that up to 40% of people don't fit perfectly. This might be because some of these patients are coming to us further down the line as the disease evolves, but actually I think in the estimates are actually closer to around 15% of people not fitting perfectly into those categories. So I'm going to move on to therapy now. I'm mindful of time. I want to talk to you lots about therapy. So when we talk about therapy, it's all well and good. I've talked to you about the 3 types of primary progressive aphasia. So yeah, that should allow you to start thinking about the types of therapy that are appropriate. But it's not only about taking a symptom-led approach. It's really important when you're working with somebody with primary progressive aphasia to think about where they are in their disease journey. I was describing this to somebody else, and another therapist that I work with, and an American therapist, and we were discussing that actually, you might meet someone at the beginning of their disease journey, and their goal might be to go to a restaurant. And somebody right at the beginning might say, right, I don't want to talk, I'm too embarrassed, I want my wife to order. Whereas somebody who's much more progressed might say to you also, oh, my goal is to go to a restaurant, but they may be more willing to practice and script what they want to order, and actually do that kind of work to improve their fluency and actually order their own meal. So it doesn't necessarily fit that somebody who is early in their disease journey will have one type of goal compared to somebody who is later. What we also need to think about in terms of the journey is the emotional journey. So where they are in terms of, telling people about their diagnosis, in terms of coping with the diagnosis themselves. It's not uncommon that I meet people and they say they haven't even told their spouse. It's more likely that perhaps they've told their spouse, but they've only told 2 family friends who happen to also be health professionals. So it's really important to think about and support people through that disease journey in terms of what they need their therapy to focus on, but also how they are coping with, how are they talking about, how are they sharing their disease journey. And of course, think about them. People don't come to therapy and say to us, I have semantic variant PPA and I'd like to work on word meanings. They say, family members say, well, what can I do to help my wife? And people say, I just want to keep being able to do my job. I love reading to my grandchildren. That these are the kinds of things that we know people with PPA want to be part of their families. They want to interact with their family members. They want to interact with their friends. I really enjoy going to the pub, and that's probably a very English goal and probably a good Australian goal. I want to be able to keep doing that. Other people don't understand. What can we do? What can we do to help them understand? And I'm so lonely and frustrated. I think it's really, really important to note that goal or that comment, that might come from the person with PPA, that might equally come from the people around them. Okay, so we know that a large percentage of people with PPA will present with depression or anxiety. In fact, a large percentage of people with PPA may have been referred to psychiatric or psychology prior to having their diagnosis of PPA. And they it's well known that these patients may kind of bounce around services before they get a definitive diagnosis, but it's also really well understood now, or slowly being better understood, I should say, is the impact on the people around them. So family members will often say, and Margaret Positbon has done some fantastic research with spouses, really exploring their journey and finding that the spouses are often really bearing the load, the burden of conversation, and their social circles are shrinking and they're becoming isolated as well. So let's talk about the evidence. So I've talked about what we need to take into consideration, but what are the actual interventions you have at your disposal in terms of the research evidence? So I'm going to start with word practice, because this is probably where the research evidence started. So there's a fair bit of research evidence that underpins this now. So what do I mean by word practice? So Regina Jockle back in 2014 published a really, really useful, I'd recommend that as in terms of reading, really useful overview of the different types of word practice for the different types of PPA. And essentially what we know now is that for people with semantic variant PPA, doing word practice that links words to their semantic concepts is really important. So semantic feature analysis, linking words to their object description, purpose, location. Whilst with logopenic variant, it's really important to also include phonological information as well as semantic information. And for non-fluent variant, perhaps really focusing more on the phonology So the first and last sound identification, that kind of thing. And the research literature in this area has increased from just case study based work, case series based work, and we now have more group analyses, more rigorous research that tells us that this kind of work can improve and maintain people's ability to use the words you're practicing. But that said, in terms of making this kind of therapy successful, it has to be personally relevant words. So I was working with a gentleman recently, and I was saying to him, it's no use working on, I'm not going to teach you how to say bird names, for example, because that's not something you talk about in everyday life. What was useful for him were the names of his children and his grandchildren, the names of the cars. I was working with a lady who loves talking about her allotment, and what was useful for her was practicing the words, that the plant names, the menu, the food she cooks using the plants that she grows on her allotments. And what we know is this therapy is most successful if it started early in a person's disease journey, and it requires a continued daily practice. So if a person stopped practicing, the effect of this therapy wears off, essentially. And I always really emphasize it's really important when you do this is to think about how, not only about the single words, but also about the sentences and the discourse that might be produced using these words, and think about things that will motivate people. We know that often there comes a point where people find this type of practice difficult. Somebody once said to me that he'd been practicing for 2 years, and he said, it started pouring salt in the wounds. I can't do it. It just reminds me of what I can't do. So often it's actually really worth engaging and identifying vocabulary people feel is important, to try and maintain that motivation for longer, and to use technology. So there are apps that you can use, of course. For example, the Tactus app that has a naming component, naming bits that you can help suggest to people to make that easier for them. But I'm always mindful that doing this type of word practice, particularly for people with semantic variant, can also become an obsession. So I'm always also mindful of actually suggesting and monitoring people. So I've had people who've then gone on to practice for 4 and 5 hours a day, so the practicing becomes a problem. So really trying to invite people to practice regularly, daily, but actually trying to ensure they practice, that the dosage doesn't become a kind of focus, but equally that people understand that they need to practice regularly so that to kind of enjoy the effects of this kind of intervention. And in terms of what this looks like, here's a quick example. I was working with the carpenter. I always use this example, and he wanted to be able to say the names of his tools in his toolbox so he could talk to his colleague and ask them for him. So we took photos of his tools in his toolbox and made them into flashcards. Actually, we did a low-tech example, and one of the really useful things was here that we put them on flashcards and we put them on a key ring, and he started carrying them around in his pocket. So although this started as an impairment-based therapy, it actually developed into an AAC device. So actually he would, over time, he'd go to the hardware shop, and rather than practicing them, he'd started using it as a way of, so he had tools, but he also had wood on his list, and he'd started using that to help him buy the materials that he needed in the shop as well. So it's really helpful sometimes to start with an impairment-based therapy, but anticipate that might become a communication aid over time. So I'm going to move on to sentences and the work by Maya Henry, who is a speech and language researcher over in the US. And she has done this really powerful piece of work on script training for non-fluent variant. So people with non-fluent variant, when she developed this therapy with them, they found that if people practiced these personally relevant scripts, that they became more intelligible on these scripted sentences, and their grammar was improved. And that actually had an impact not only on the sentences they were practicing, but it carried over to untrained sentences as well, and untrained topics. So again, this is a therapy that required people to practice. So it's a high dosage, high intensity, high dosage. And they developed a hierarchy of tasks to help people with their practice. I recommend going to this article where they have a really practical protocol laid out for the intervention. But I just wanted to give you an example of what that might be. you know, this is a very British, English, London centric, North London centric script. It's about a soccer team, which my son supports. And, you know, so this is the type of script somebody might have about something they're interested in. And some people might have a couple of different scripts. Or I was working with somebody recently and we had a current script that they anticipate or hope they wouldn't have to use all that for all that long. So they wanted to write a script around COVID, but we're anticipating that hopefully that will have an expiry date. But equally, some of these scripts, I wanted to show this example because somebody might write a script like this, but this looks a lot like the kind of content you might see in a communication aid as well. So it's really valuable to think about doing these impairment-based therapies, but also, again, think about how they might become something different in the future. So talking about your favorite football team or soccer team might be something that will be helpful to include in a communication book over time, so people understand what your preferences and likes and values are as well. So moving on from that impairment-based work to the more functional interventions. So in 2019, we published a systematic review of the functional interventions, because I wanted to know, in therapy, my feeling was that actually we were doing impairment interventions, but we were doing a whole lot of other work. So I wanted to have a look at all that work and see what that literature looked like. And we found 19 studies, and they were really different, lots and lots of different types of studies, but what they had in common was that they all built on strategies that people were already using in their daily life, not introducing new ones, but building on existing strategies and incorporating the context. So working with people around the person to help them enhance their use of that strategy. Unfortunately, it was really difficult to compare these studies, because at the moment, these studies are kind of the newer literature in PPA that focus on functional therapies, and they're mostly based on case studies still, and smaller case series, and they lacked commonality in terms of outcome measure. But these are the kind of things we were seeing. So some really lovely work looking at the use of communication aids, such as smartphone use for people with semantic variant, you know, using the photo app to create a shopping list rather than a written shopping list, photographing a can of Coke and the pint of milk, and doing picture matching to enable people to go shopping at the corner store still, or doing developing aphasia friendly recipes and training people to use those recipes in daily life. Also, this kind of looking more at total communication in a way. So Amy Mooney over in the US asked people to take photos of what they were doing during the day and then come back and tell their family members about them. And they compared the types of conversations they had without a photo, with a photo, or with a photo and some keywords. And they found that just with a photo, the effectiveness and the volume of content was significantly increased compared to not having a photo. And I really like this, because this is such a normal thing nowadays for us to get out an iPhone and find a photo and share a photo in a conversation. And you can see here, this is a photo of me and my younger sister where we were bridesmaids. And it's so powerful to see those keywords. It conveys so much information. So I'm going to just finish the presentation with a couple more slides talking about communication partner training. So we asked therapists in the UK what they actually did. I've talked about what I thought people were doing, but along the bottom here you can see some different types of intervention, and here is the number of therapists, and pink what represents what therapists report they were doing never or only occasionally, while green represents what they said they were doing always and often. And what you can see here is that the more impairment-based work is not commonly what therapists reported doing, but it's actually the communication partner training work that they reported doing. So my research work has focused on developing a communication partner training program for people with PPA. And I based this on the Better Conversations with Aphasia, because this is what people reported using. If they were doing communication partner training, people said they borrowed from the stroke and the TBI literature, and so and use that with people with PPA. Yet when we talked to the families and the speech therapists and the people with PPA themselves, they felt they needed something that was tailored to their needs. So that was what my PhD focused on was developing the Better Conversations with PPA program, which isn't yet publicly available, but I'll give you a very brief overview of it. Essentially, we developed a protocol for 4 sessions because that's what speech therapists in the UK reported they had available on average. So where you make a video of conversation, and then of the couple's conversations, then you talk to them about what conversation is in terms of turn taking, how it works in terms of conversation breakdown and repair, the use of test questions, or correcting that we see sometimes in family members of people with communication difficulties. And then you watch the videos that they've made together and a few clips from them, and you try and support them to identify what the barriers are in their conversations and what's facilitating the conversations, to set goals around what they want to do more of or less of, and then practice those in the therapy, and practice doing more or less of them and problem solve that, and start planning for how the conversations might change over time into the future. We've just finished a pilot, a randomized controlled pilot feasibility study using that intervention and comparing that to no treatment, to see if it is feasible to do a randomized controlled trial of Better Conversations in across 11 NHS sites across England and Wales, actually. And our initial results, I can tell you, so they indicate that this is an intervention that is acceptable to speech therapists. People with PPA and their families found it, they were very positive about the intervention, and the people who participated completed the intervention from start to finish. There were some people we found that weren't appropriate, and that's, I think, because often people with PPA are referred quite late to community services in the UK. I'm sure that's similar over in Australia. And we are looking at the outcome measures now to see what the most useful outcome measure is, with a view to doing a multi-centre international randomised controlled effectiveness study. So I'm going to finish now by just emphasising the value of working with PPA in the pandemic. So this is an article written by one of my colleagues at the PPA support group, and I want to draw your attention here to the impact of the COVID pandemic on people with PPA and their families who cannot understand how the pandemic impacts on their lives. And we've been doing lots and lots of work, and in my clinical work and with the support group, we've found there's so much need, so many people contacting us, so many people with PPA are struggling, such that actually the membership of the support group that we have that I work with has more than doubled during the pandemic. And so I wanted to draw your attention to support in this way. And I know there's a wonderful support group in Melbourne run by Fionn Walker, and in Sydney, I know that Kathy Taylor does a lot of work with running groups for people with PPA. And we have this rare dementia support group. We're now running remotely, and we have 3 or 4 meetings a year. And we've found that we're having more and more international members. I know that in Sydney, Kathy was disseminating some of the links to her members, and I just wanted to share the resources with you, because we've produced lots more educational resources, videos of people talking about their experiences of living with PPA. And this is me in one of those videos talking to Helen, who has a mixed PPA, about the value and the impact of working with a speech therapist. And we tend to find sharing these resources with people with PPA and their families is really helpful, because often people feel they're living on their own with this and coping on their own with this. So we wanted to create some resources to share, especially during the pandemic. So I'm going to draw to a close. Please do watch this space. We'll be sharing much more on the work we're doing. Please do get in contact. I'm always keen to collaborate and problem solve and support people. And I have a blog where I talk about the work I'm doing, and do follow me on Twitter. And this is my very last slide, to thank all the fantastic people who've helped me over the years in terms of my research work. So thank you very much.
Thank you, Anna, so much for such a comprehensive presentation. And we've had so many attendees today that are just really lapping up all your wonderful knowledge and expertise. And it's really exciting what you're doing in this space moving forward, and how you're supporting the community throughout COVID as well. So thank you so much. We've got so many questions, so we'll get through as many as we can. I'll just remind everyone that the presentation has been recorded so that Anna's slides will be viewable through the presentation. But if you would, if you are interested in more information and to contact Anna, please do so through her email or Twitter. I know a few of you have been asking about access to Anna's slides, so I'll let you liaise with Anna going forward. So thank you for all the questions. Helen has asked, what is the one best assessment to make a differential diagnosis?
The one best assessment to make a differential diagnosis. So we asked speech and language therapists in the UK what they used, and they used the comprehensive aphasia test. I use that clinically also, and if I had to use one, even the comprehensive aphasia test has many subtests to it. So what I tend to find, if I have to choose a couple of subtests, I err towards things like single word naming and single word comprehension, digit span and sentence repetition, picture description. So there was some work done by some researchers in Germany, and they actually said picture description and single word naming task. They talked about the Boston naming task and the cookie theft picture description as being two of the key things to use. But I have to say, I'm also a huge fan of conversation. And that's because I think that's really important to plan therapy as well. So it's one thing giving a diagnosis, but in reality, finding out how people are managing, it's really important to look at real life conversation.
Lovely, thank you. Rajat goes into a little bit of detail about a clinical case of someone with overlapping symptoms of semantic and phonological variant of PPA, and then discussing the mixed PPA. You did cover this a little bit in your talk. Did you want to talk a little bit more about that, Anna, to clarify?
Yeah, I can do. I can just see the comment from Rajat actually, and I guess I would also add to that I think that the research literature that I'm presenting on is about the English-speaking populations, and I know that dyslexias might look a little bit different across people who speak different languages and across people who are bilingual or trilingual, or who and that's a whole nother spectrum of you know, people. Bilingualism is a very complex area, and we're really only now getting to understand that in more detail. So I would say that that literature is developing. But if I were to talk about the mixed variants, I think it's actually pretty common that people don't fit perfectly into these strict criteria. And I'd say that my experience clinically, the consultants that I work with, they do sometimes go on the balance of probabilities. But if they're trying to prescribe a medication, so for example, if they feel somebody's got a logopenic variant, and one of the reasons thinking about logopenic variant is really important is that for these people, it might be that they are appropriate for pharmacological interventions like donezepil or memantine because of the underlying Alzheimer's pathology, which is not appropriate for somebody with semantic variant or non-fluent variant because of the different underlying proteins. So in that case, they may take a bit more care about that, refining that diagnosis. I hope that helps, but I'm always happy to speak directly, so do get in touch with me, and I can always link you in with one of our professors, our neurologists who I work with.
Oh, that's wonderful. Laura asks, is there evidence that early use and introduction of AAC has impact on ability for long-term use?
It's a really good question. So the kind of anecdotal research and the clinical knowledge I would say yes, essentially, and I think that's more about acceptability, education. I'm on an international group with some speech and language therapy researchers from the US, Canada and Australia, from Sydney, Perth and Melbourne. Some of the people I've mentioned already, like Marg Posibon, Kathy Taylor and Jade Cartwright and Leanne Ruggero, sorry, are on it. And in that group, and what we were all agreeing on recently actually is the importance of introducing information, educating people early so that they can make decisions about their own care. And part of that is telling them what the interventions are available, so they have agency around making decisions about what they want to have into the future. So often we do find actually telling people what is available is really helpful early on. So it's increasingly I'm finding that people with non-fluent variant are asking me about voice banking. Is not appropriate for many people, but certainly that people are really interested in exploring it early on. And I think it's really valuable to have agency, and somebody talked about having a voice in their future healthcare, and I thought that was really powerful. So yes, it is really valuable to introduce earlier.
Thanks, Anna. Laura asks, how do you suggest supporting a patient that has been diagnosed late and is quite advanced in the disease?
That's a really good question also, because this is probably one of the more common patients we will see. And I often find one of the really valuable things to do is talk to the people around that person. I do a lot of work, lots of phone calls where I talk to family members every 6 to 8 weeks, and we just brainstorm what strategies to use. And a lot of the work I do is around focusing them from verbal interactions, from verbal conversation, to actually think about non-verbal conversation. I was talking to somebody recently. It's really common that people say, well, what's the point? We don't talk anymore. There's no conversation. So I spend a lot of time saying, well, someone was saying about her relative with semantic variant that he just stood at the window and looked at the birds, and she said, and I bought him a bird feeder and I hang it in the tree, and sometimes I just stand next to him. And I said, well, that's a conversation. You're interacting with that person. And another gentleman I was working with said, well, we walk to the park and we walk around in silence. And he said, but we hold hands, and I try and encourage her to choose the route. So she squeezes my hand or points her hand, saying, well, that's a conversation, that's an interaction. We do lots of work around looking at non-verbal stuff, so encouraging people to think about washing up as an interaction, a turn taking. Think about, people with semantic variant often have strength in numbers, so thinking about dominoes or puzzles or some kind of game, or often art is something that people rediscover. So thinking about other mediums, other non-language based interactions that people can have is really, really helpful, I think.
Great. Sharon asks, what is your opinion of how primary progressive apraxia of speech fits in with all of this? And she's got some comments there around a clinical case.
Fantastic. So I actually was having a really similar conversation with one of my colleagues in the UK recently. So I think you might have noticed on the slides, I didn't say this out loud, but there is some discrepancy in terms of terminology that is used. And so increasingly, I think through this international paper written in 2001 by Gorno Timpini, there's less heterogeneity in the terminology, but nevertheless there is some heterogeneity, and there's some discrepancy in what different people think might be the diagnosis. So I probably would say with the primary progressive apraxia that in my clinic they probably would be categorized as somebody living with a non-fluent variant PPA, but some clinicians, some consultants, neurologists, psychiatrists or geriatricians believe actually they should be two separate categories, that people who have a pure progressive apraxia should be categorized separately to somebody who has an agrammatism and an apraxia. In terms of our work as a speech and language therapist, I think actually we're in a similar place perhaps to where stroke aphasia was a couple of decades ago, or more than that, where I actually think we probably have there's more benefit sometimes in looking, rather than at the diagnostic categories, at the strengths and difficulties that person's living with. So, and actually basing our interventions, our work with them around that, and even our education, because what we do know is even somebody with a pure progressive apraxia is going to progress And we do know that as they progress, they will become more, there's a chance they'll become mute. And we know that what kind of therapy options might be available. And we know the impact that this might have on their loved ones. So thinking about it more in terms of that, I think, is a useful way forward therapeutically.
Okay. We might just do another couple of questions if you're okay, Anna, to go a little over time. I'm sorry we won't get to all the questions, but please do reach out to Anna directly via email or Twitter. Someone asked, how long should we recommend daily home practice? And how many words and items should be practiced, etc.
That's so I think this is again really individual to the person you're working with. I try and suggest to people to try and stop people become obsessed with things, and to also give some reprise from continuous practice. I suggest to people that they practice Monday to Friday or Monday to Saturday, and I suggest, if we look at, based on the research evidence, that people practice for, say, half an hour a day. And I tend to find that when we're developing an intervention, starting off with, say, 20 words, when you're trying to introduce this, even when you're working with somebody with stroke aphasia, you have to start somewhere. And you tend to start with a round number of, say, 20 words. Even when you're working with somebody with a memory-led dementia, if you're doing an exercise with them, you have to start somewhere. And so with these kind of word practice, I tend to start with, say, 20 words, and as long as they're person-centered. And some people will increase that list. In fact, some people will come to therapy having already started making lists themselves. So you can actually often, work from there. What are people writing down? I was working with a lady, and she already had a list of, she liked talking with her husband about, she loved music, and she already had like a list of about 15 artists that she loved listening to, and their kind of main albums. So we started there. And then I've worked with a gentleman who he wanted to work on a couple of 100 words. So he got up to about 200 words, and he would rotate them. And I think that's really important. As a word list increases, not then letting that practice go from 20 minutes or half an hour to 2 or 3 hours, or 4 hours, actually asking people to work that out. So rotating briefer lists. Similarly with scripts, actually. I always, with the student speech therapists, I get people to write a script for themselves. And what people then often say is, it's really hard to think of one thing to write a script about. What's the most important thing I want to convey? And so actually, I often say, if you're going to work on script training and it's useful, maybe starting with 3 and working on rotating those, and you can drop some, like, the lady who wrote the COVID script. I have another gentleman who wanted to write a script on Brexit and his opinion on Boris Johnson, our Prime Minister, and with the hope that, and we were laughing, that with the hope that for this gentleman, he didn't want Boris, he wasn't a big fan of Boris, so he was hoping that this would be a script he'd only use for a very short space of time, and that was kind of part of us practicing that script. So it might be that you then rotate those scripts, or drop some scripts and write new scripts, but there might be some, such as a script about the person's diagnosis journey, that remains a constant for that person.
Thank you so much, Anna. We've had lots of messages in the chat thanking you so much for such an inspiring and a practical presentation today, and really appreciate you getting up so early, UK time. I'll just share the final slide to let you all know that we have, if you have a moment, we do have a poll survey that may appear on your screen if you'd like to suggest future topics. And clinicians were actually interested in PPA, and that's how we got Anna involved today. So it's a really great way to let us know what your interests are. And we look forward to hosting the next seminar on Wednesday, the 31st of March. we are very excited to have Dr. Emily Brogan from Edith Cowan University to present what is therapy, treatment, fidelity and aphasia. So we'll see you then Perth time at 2 o'clock. And thanks again, Anna. We look forward to seeing you very soon.
Thank you.
Thanks.